Alright, so just bonus session. I happen to have some time right now. So we were now up to bone and mineral disorders, right? So this is now going to encompass a bunch of your disorders related to PTH mainly. So if we go back to the main top part right here, we see osteoporosis, Paget disease of bone, hyperparathyroidism, all three of which are topics that are from step one. There's nothing brand new about either of them. So it's a pretty easy, straightforward topic, right? So they're going to have a figure here reviewing mainly the things that are related to bone, which are calcium and phosphate regulation. So here I quickly put a little equation that's going to be pretty significant. In fact, I'm going to go ahead and put this in bold and red, right? So you can do that in your variation of the book too, so you don't miss the equation as you sweep by from this page. But this is a very useful equation, not only in CK but in medicine in general. I mean, when you start practicing in real life, you're gonna have computers doing everything for you anyway, so that's a different variation right there. But here, this ends up being a key thing that you're gonna need to see in some questions, and you'll see where applying this general equation will actually help you simply just solve a question correctly. So you'll see where we use that. I believe that question should be here in this section somewhere. So first thing they mention osteoporosis. They tell you on the side here, do not confuse osteoporosis with osteomalacia. Osteomalacia is a mineralization defect often caused by severe vitamin D deficiency that presents with bone pain, low calcium phosphate, and secondary hyperparathyroidism. Osteoporosis is a common metabolic bone disease characterized by low bone mass. It most often affects thin postmenopausal women, especially white and Asian individuals, with risk doubling after 65 years of age. Men are also at risk for osteoporosis, but the diagnosis is often overlooked. Men also often in the general public tend to have a stronger muscle mass or a stronger muscle build, right? A higher muscle mass and a stronger muscle build. So what happens is, since the muscle is what's actually anchoring onto bone and giving people the ability to move, if there's enough muscle mass and muscle power, the bone issues don't often end up causing enough symptoms for osteoporosis to be something to cause patients to come in. Common asymptomatic, even in the presence of a vertebral fracture. Risk factors are smoking, advancing age, alcohol, a history of estrogen depleting conditions like amenorrhea, eating disorders, early menopause, or hypogonadism in men. Physical activity, inactivity, uncontrolled hyperthyroidism, hyperparathyroidism, chronic inflammatory disease, corticosteroid use, and Cushing syndrome. So all of these are, of course, things that you're not completely out of whack about. You know about them for the most part. One thing that a step has enjoyed asking questions about is this, right? So they'll be like, what can you advise patients to do? And then they'll have all these weird weird answer choices that you can pick from regarding different kinds of physical activity that might help them against osteoporosis. And we're going to see that pretty soon in the treatment section. So when we get there, I'll talk about it. Going to come back to this in a bit. Let's keep going. An exam may reveal hip fractures, vertebral compression fractures, which can present with a loss of height and progressive thoracic kyphosis, and or distal radius fractures, like a Cole's fracture, following minimal trauma. So all of these things were actually more adequately discussed in first aid step 1. So if we go down to pathology, and once you pass all the endocrine stuff that's related to thyroid and sugar, they start talking about hyperparathyroid, right? Hyperthyroid, Laron syndrome, diabetes. Let me see. Oh, actually, you know what? In step 1, they moved it. Previously, it was here, but they moved it to something that they now talk about. With the I believe the MSK section, the osteoporosis topic. Yeah, right here. So. Here's your osteoporosis topic, right, from first aid step 1. You're going to have to go back and take a look at most of these things. Check out any of these practice questions right here, so you can have that for yourself. Or you can just pause the video and check it out. But generally speaking, the book did show you your vertebral compression fractures, where, here it's way too obvious. But what you'll often see in some less blatantly obvious questions is that you're going to have, your vertebra, and you should have space in between full of the gel that helps you be able to kind of manage not getting bone to scratch into each other, right? And here you can see this one is all messed up. It got compressed pretty hard, right? And then this one is normal right here. This one is good. So what you'll see in these pathologic images of these patients is that they're not going to be in these perfect heights, right? Perfect heights. Generally speaking, they should all have about the same height when you're visualizing it, when you're just eyeballing it. And then if you see one that seems to be slightly thinner, right, slightly thinner than the rest of them in terms of height, right? This is how much smaller I kind of made this one. The rest of them are about the same height as this red line I made. Right, so you see how I lost that much bone here. So that's a compression that's occurring, a compression fracture. There's a bunch of trabeculae stuff in here that holds this up. If you have osteoporosis, you won't have those vertical lines I'm making. So then it starts to lose its support. Right, so it should look nice like this, and without the intervertebral disc getting messed up. If the intervertebral disc starts getting messed up, what you'll often notice is the bone starts getting closer to each other, and when bone touches bone, that hurts a lot. Right, so that's what they're showing you here. All right, there were the Coles fractures as well. This thing right here, where you have a fracture of the wrist, right, in a very weird manner, and this can happen because, of course, oftentimes when you have things that put pressure on your palm in that direction, whether you're falling or trying to hit something, this can break like that, right? And the key term was mainly just trabecular thinning, right? So here, like for this question, the correct answer choice for osteoporosis was trabecular thinning with fewer interconnections, right? So those are some of the key terms you look for. We're going to be looking at this more in CK, right? The different ways to diagnose it, which key things you're supposed to really care about, and then how to manage it. Right? So bisphosphonates often tend to be the key pharmacological thing that's getting tested, because bisphosphonates have a really intense side effect where they can cause this weird ulceration that occurs in the mouth. So patients who take bisphosphonates need to make sure they don't lay down right after they take it, and they should drink a lot of water with it, right? So we're going to see all of that soon enough. Compare that to osteomalacia, which was warned right here to not confuse the two, right? So osteomalacia is not a metabolic bone disease. Okay, osteoporosis is a metabolic bone disease. Osteomalacia, however, is just a mineralization defect. It's basically the male version of rickets. It's a lack of vitamin D that leads to a whole conglomeration of issues, right? Low vitamin D leads to, of course, not having enough calcium, which then leads to more PTH secretion. And PTH is also known as phosphate trashing hormone, so you end up losing a lot of phosphate. Right? And in any question where you're going to have these up and down arrows, they can randomly throw ALP into there. So you need to consider, is there a lot of osteoblast activity or not? Anytime there's a lot of osteoblast activity, you're going to have increased ALP. All right? So remember, osteoblasts are the ones that make bone. So if you're doing something where you're trying to make bone, that requires an alkaline environment, and that's why you have increased ALP in those patients. So that's what you're going to see in that aspect. So here they go on with the diagnosis aspect of things, right? Osteoporosis is the most common cause of pathologic fractures in thin women and men over age 60 years of age. Diagnostic test, dual energy X-ray osteometry, which is just a DEXA scan, recommended as screening test for all women over 65 years of age and men over 70 years of age, and those with other risk factors for osteoporosis. Osteoporosis is generally a bone mineral density issue where you're going to have a T-score 2.5 standard deviations less than the normal, right? And that's kind of what they're trying to explain here. They didn't really do that good of a job, but they did mention it. Either you're going to have a T-score of less than or equal to negative 2.5, or by a fragility fracture, right? Fall from standing high, minimal trauma, etc. So that's the thing you're looking for. The T-score being negative 2.5 is basically 2.5 standard deviations less than normal. Osteopenia, on the other hand, is a T-score between 1 and 2.5 standard deviations below normal. It's like something that's pre-osteoporosis in a sense. All right. Lab tests look for secondary causes by measuring calcium, phosphate, PTH, TSH, free T4, liver enzymes, creatinine, and electrolytes. If there is estrogen deficiency, or there's hypogonadism, such as in a male who might have had some kind of issue where they lost their testes. If any of this is suspected, then you need to measure the reproductive hormones, FSH, LH, estradiol, and testosterone. Right? And one of these things, or a combination of these things, could be the reason why the patient is presenting with osteoporosis, because osteoporosis is not generally what's considered physiologic aging, right? So it's not something that's supposed to occur as you grow old. Here's tea. Okay, so treatment. So this is the question you're going to get. You're going to get a question about osteoporosis. The patient's going to be asking you, what should I do to, maybe the patient's going to come in and say, my mom has osteoporosis. What should I do? And it's going to be a female patient. What should I do to lower the risk of developing osteoporosis too? And then they're going to have all these exercise advice to do, but the only exercise that really matters for preventing osteoporosis are weight-bearing exercises. Right? Weight-bearing exercises, which are basically what's in the general public considered the type of exercises men do for the most part, right? Weightlifting, weight-bearing, running with weights, etc., those kinds of things. Right? So those are, you're going to pick any answer choice that's related to using weights to pretty much put pressure on bone and cause bone to develop even more strongly, and also kind of develop a muscle connection that'll help the bone stay up. The best initial treatment is just to put them on any of these dronates, right? So zoledronate, alendronate, bisoldronate. Remember, this is also called zoledronate. So any onate in chemistry basically means it's an acid. That's all this means. For example, alendronate is alendronic acid. Right? Risedronate is risedronic acid, and that's it. So these are all your bisphosphonates, which are used in the treatment of osteoporosis, but it won't be used for osteopenia. Other things are teriparatide, very interesting medication which acts as a PTH analog and helps you basically get more calcium. Denosumab, which is a monoclonal antibody to rank ligand. So we'll see how this works. We'll go back into step 1 and look at that. And then a selective estrogen receptor modulator like raloxifene. Right, so what is this monoclonal antibody for rank ligand? Now that is a pathophysiology of things that you definitely need to make sure you have a good understanding of. So we see that, let me see, I think it's right. Where did I talk about it? Which one is right after all of these things? After musculoskeletal? Okay, so here we see the bisphosphonate. That's one thing you need to definitely know. Right, the bisphosphonates you have, this is how you can see here what's happening, right? So you have osteonecrosis of the jaw. This is the key side effect you really care about, right? So there's a weird ulceration in the mouth associated with IV administration, and affects the mandible twice as often as it affects the maxilla. The majority of cases are also preceded by dental procedures before the IV administration. Patients can also get esophagitis, which is a very high-yield topic. Step just loves talking about esophagus problems, right? Achalasia and stuff. So it's going to be a question that isn't achalasia. It's not going to be that the patient is having any kind of trouble swallowing and drinking fluids. It's mainly going to be just an inflammation of the esophagus, right? Can be used for many things, but the main thing this basically does is inhibits osteoclast activity, right? Osteoclasts break bone and it stops it. These guys over here are your osteoblasts, which are making bone. All right, so that's one thing. Now, I really wish I could remember where it is. Oh, perfect. Okay, found it. So right here, I talked about osteoclast differentiation. Right. So this is a big topic in step 1 where they talk about the cell biology of bone. They just summarize it all real quickly here. But knowing this is very critical because this is what we're studying. Right. We're looking at bone pathologies. So you have your osteoblast, your osteoclast, the main calcium and bone hormone, PTH, and then the estrogen, which is critical because women are at more risk of osteoporosis, especially after menopause. So what's this denosumab thing? So on the top I wrote, osteoblasts release rank ligand. a thing. It's just a ligand. It's just a little thing that's supposed to go and then bind rank on osteoclast, right? So osteoblast, the guy that makes bone, also makes the ligand. This ligand then goes and connects to some receptor rank on osteoclast, the guy that breaks bone. This connection induces NF-kappa B to work inside them and lead to fusion activation survival, leading to a multinuclear osteoclast. This is something that's described in a this entire thing actually is a very nice thing described in a very articulate UWorld image that I do not have here, probably because when I was putting this together, I didn't have the paid version of Foxit, so I couldn't add blank pages, and I couldn't find space to add that picture anywhere else. But you can probably find it somewhere. So osteoclast differentiation, UWorld, you should be able to find it. Osteoclasts are going to be that thing though. They're going to be this multinuclear. Let me see if I can try to find it really quickly, but osteoclast differentiation, UWorld. That should be all it takes to find that. Yeah, so here it is. Let me see if it gets clear. Not a clear picture. Alright, this picture should do the job for us to at least have this conversation, and then so it's hard to find perfect pictures sometimes too, because UWorld doesn't really want you to do that, right? So here you can see you have your osteoclast differentiation topic, right? So things like MCSF or your macrophage colony stimulating factor are going to cause differentiation. You have your osteoclast precursor, all right? And then here in the middle is your osteoblast, okay? So there's a couple key players here that are going to be one of the parameters of your questions with up and down arrows, right? So they're going to ask you, do you have high osteoprotegrin or low osteoprotegrin? Do you have high rank or low rank and stuff like that? These two guys are the key things here. So your osteoblast makes this purple ligand called the rank ligand. This rank ligand can go connect to rank in your osteoclast precursor, which then has fusion activation survival, right? Fusion activation survival, where all your osteoclasts combine into this one massive multinuclear osteoclast. Right? So here, if this happened, that means that you must have low osteoprotegrin. You have a high rank ligand, right? A lot of rank ligand, which connected to rank and allowed this to occur. So what's osteoprotegrin? Well, osteoprotegrin is protective. Right? So protegrin and protective, you'll be able to think of it like that. Osteoprotegrin is a decoy, right? It's a decoy guy that also connects to rank ligand. And once this guy connects to rank ligand, the rank ligand cannot connect to your osteoclast. So it's basically a competitive inhibitor in a sense. Right? So it stops the correct connection from happening, and then you do not activate osteoclast. Right? Osteoprotegrin competitively binds rank ligand and prevents its binding to rank. This is happening because you must have a lot of high osteoprotegrin, and not enough rank ligand is now available. Right? So when this happens, when you have high osteoprotegrin, you have decreased osteoclast formation and survival, which is nice because you don't really need a lot of osteoclast. You don't need all that bone breaking to occur. So that's what we were looking at right here. Osteoclasts come from monocytes through the use of PU1 and MCSF. Osteoprotegrin, whose production is stimulated by estrogen, is a decoy receptor for rank ligand, which prevents rank ligand from binding to rank, thus inhibiting the differentiation of osteoclast precursors. The osteoporosis drug strontium ranelate also upregulates osteoprotegrin formation. Denosumab is a monoclonal antibody that acts like osteoprotegrin to inhibit osteoclast differentiation. Right, so strontium ranelate is something you can give to make people have more osteoprotegrin formation, whereas denosumab is a fake version of the osteoprotegrin. Fibroblast growth factor induces the formation of more osteoblasts, so bad osteoblast receptors lead to dwarfism. That's something that's related to the fibroblast growth factor issue regarding achondroplasia. Right, so that's where you see the dwarfism issue there, and I think that's one of the... Yeah, it's not here, but it's somewhere in the book. Is it up here? No. Yeah, I'm not going to find it right now. But yeah, wherever... the order of topics in the book has changed so many times that I don't really have good retention of it anymore. But this FGF receptor, I think it's FGF receptor 3 or something, is the issue in achondroplasia. And that's the topic they're talking about right there with the dwarfism. TGF-beta increases osteoblasts and causes apoptosis of osteoclasts. So TGF-beta is actually a good thing. And then IGF-1, which is again back to endocrine, IGF-1 also increases osteoblasts and stops metalloprotein MMP13 from working, which is a collagenase 3, and that thing is also responsible for restructuring and mineralizing bone. So pretty critical set of basic notes up here that are then also taught in the book, but not as perfectly. But what we're basically seeing here is that we need osteoprotegrin, and to have osteoprotegrin, we need estrogen. Right? Estrogen actually inhibits apoptosis in bone-forming osteoblasts, so osteoblasts live longer, and induces apoptosis in bone-resorbing osteoclasts, so you stop breaking down bone. Causes closure of the epiphyseal plate during puberty. Estrogen deficiency, either because of surgical issues or postmenopausal, leads to more cycles of remodeling and bone resorption, which increases the risk of osteoporosis because they're going to have more activity of their osteoclast. Right, so that's what you're basically seeing right there. Let's go back to endocrine thyroid path, parathyroid path. Yeah, okay, we'll stop right here. So coming back to here, you can use all these things that basically rely on osteoprotegrin activity. Complications, we already know fracture. A fracture is the most devastating consequence of low bone mineral density. Osteoporosis, carrying a 50% increase in mortality in the year following a hip fracture. Right? Upper GI side effects such as reflux, esophagitis, and esophageal ulcers are common reasons for oral bisphosphonate intolerance. Right? So if a patient already has some of these issues, then you can't really start them on bisphosphonate. So that's something you have to be careful for in the question, right? If you get a question about a patient with osteoporosis, and then they're telling you that it's clearly osteoporosis, and you need to figure out what you're going to use to treat them, you can't pick the the bisphosphonate, because bisphosphonate is not going to be good for them if they have any of these issues, like esophagitis already. Right? You never really want to give somebody medication which has side effects that can lead to problems similar to problems the person already has themselves. Right? So let's take a look at some of these questions here now before we move on to the next thing. So this question right here, this one was really interesting because 30, 30, 30, that's the breakdown of everyone that chose different answer choices. A third got it right, and then 2/3 in groups chose 2 different answers. So 65-year-old woman comes to the office for follow-up. 2 months ago, she was found to have low bone mineral density on screening DEXA. Her serum calcium and vitamin D were within normal limits, and weekly alendronate therapy was prescribed. Okay, so they basically they basically diagnosed her with osteoporosis and started the treatment of alendronate after doing the DEXA scan. After starting the bisphosphonate, she had burning epigastric discomfort and nausea, which improved with over-the-counter antacids. Okay. She also has hypertension, for which she takes chlorothalidone. She takes no other medications or supplements and does not use tobacco, alcohol, or drugs. She consumes a balanced diet and performs weight-bearing exercises regularly. Good. Blood pressure is fine. Pulse is fine. Physical exam is normal. Lab results show normal sodium, normal potassium. Bicarb is 34. Creatinine is high, 1.7. Calcium, 12.8. Phosphorus, 1.2. And magnesium, 1.1. Serum creatinine was actually 0.8 2 months ago, so it definitely got a lot worse. Right? It's very, very bad. It almost went up by 1 entire point if it was 0.7. What is the most likely cause of her hypercalcemia? Okay, and this question was really out of place, basically, because this question, what's causing her hypercalcemia? Well, you really just have to relax and think of the fact that everything is going great and everything that she's doing is basically standard, except for one thing: her over-the-counter antacid. We've seen this before in one of our previous videos where we were talking about a patient who started losing weight and started employing an over-the-counter weight loss remedy, which just happened to be putting that patient's thyroid stability out of order. I messed up that patient's thyroid axis. So here we're seeing the same messing up of the axis. Something must be wrong somewhere And the bisphosphonate isn't what's going to really do anything to her calcium levels, right? The bisphosphonate doesn't do anything to calcium. And her osteoporosis, calcium levels are not that big of a deal there. So then the only thing that could have caused it was the excessive calcium carbonate intake. It's most likely that her over-the-counter antacid is a calcium carbonate antacid. The other answer choices don't really make sense, right? So here, increased release of PTH or renal tubular effect of thiazide diuretic. Okay, so these two answer choices for why her calcium is high, I can see how a person could, quote-unquote, come to this thought process and pick this answer, but it wasn't really clearly given that, these are actual things that are going to happen. And if you check this out, you see how it was pretty ridiculous that 60% of people chose these wrong answer choices. This question is about something CK likes a lot: milk alkali syndrome. This is going to be a question that pops up for adults, for kids taking too much milk in general, all these things. This patient has acute kidney injury associated with hypercalcemia and metabolic alkalosis because her bicarb is high. It's supposed to be between 20 and 28. In light of her recent use of over-the-counter antacids, this most likely represents milk alkali syndrome from calcium carbonate use for heartburn, also taken for osteoporosis. Evaluation of milk alkali syndrome should include measurement of serum PTH, which would be expected to be suppressed. Additional findings can include hypophosphatemia due to intestinal binding of phosphate by calcium carbonate, and hypomagnesemia due to decreased renal reabsorption of magnesium. Initial management includes isotonic saline followed by loop diuretics. And of course, to stop taking the over-the-counter antacid, this milk one too much. Primary hyperparathyroidism, which is this answer choice, increased release of PTH. Well, increased release of PTH can cause hypercalcemia and increased renal production of vitamin D, but it doesn't really cause alkalosis. It wouldn't explain why the bicarb is so high. Right? When you look at these serum labs, you would highlight this because that's high. That's alkalosis right there. You would highlight this, which indicates kidney injury. And those two should be very blatantly clear without having to really check labs or anything. So primary hyperparathyroidism doesn't explain that. And then the second answer choice, the renal tubular effect of thiazide diuretics, or you would have to remember what thiazide diuretics even really do to pick this. Overdiuresis with thiazide diuretics can also cause hypercalcemia, hypomagnesemia, and a contraction alkalosis of renal insufficiency. But this is usually associated with hypokalemia, not hypophosphatemia. A critical little difference that, again, most students wouldn't really remember that well, right, to be able to catch. If you do remember it that well, then that's great, and you're good to go. But if you don't, then you can't really pick that answer choice. This is a very intriguing question that a lot of students messed up. Now, there's also this topic of how it all relates to your magnesium levels, right? So if we look at endocrine physio here and look at the parathyroid function, you're going to see that magnesium has a very weird connection, right? A very weird connection worth knowing. So let's take a look at PTH real quick. So PTH has the goal of increasing blood calcium at all costs, even if the cost is stripping it from bone. PTH strongly promotes osteoclast activity, breaking hydroxyapatite of the bone into calcium and phosphate. Osteoclasts don't have a PTH receptor. We already saw how osteoclasts get activated. Osteoclasts actually have a rank receptor. The rank ligand hormone, which activates rank, is secreted by osteocytes and osteoblasts, who do have PTH receptors. So PTH, always remember this. This is something that also pops up in questions, the pathophysiology of how PTH leads to osteoclast activity. PTH indirectly activates osteoclasts through the use of osteoblasts and their rank ligand. Right, so PTH indirectly causes increased osteoclast activity by causing osteoblasts to secrete rank ligand. Like vitamin D, PTH stops the kidney from excreting calcium, but PTH also promotes phosphate excretion. That's why you could think of this as phosphate trashing hormone. Remember, providing calcium and phosphate like substrates together, so the same way vitamin D does, would promote the deposition onto bone, or worse, the spontaneous mineralization of calcium phosphate on blood vessels. So PTH wants to increase calcium in the blood, phosphate has to go. Lastly, PTH stimulates vitamin D activation. So that means that PTH and vitamin D are actually brothers. They don't work against each other. They don't work as opposites, right? PTH and vitamin D are partners, not opposites. Vitamin D will then go stimulate gut absorption of both calcium and phosphate so you can rebuild bone and excrete phosphate if necessary. So PTH gets rid of phosphate, but vitamin D is the guy that will help you replenish that phosphate. All right. So that's the key pathophysiology thing that we've been talking about with PTH, estrogen, osteoblasts, and osteoclasts being the four main regulatory players of your bone disorders. And what you're seeing over here is how magnesium has a role here. Right? So again, what causes PTH to increase? Well, there's three things that will cause PTH to increase. Either you don't have enough calcium, you have too much phosphate, or you have slightly low magnesium. Now, if magnesium gets too low, then that actually leads to a decrease in PTH. Right? Common causes of super low magnesium or loss of magnesium in general include diarrhea, aminoglycosides, a lot of diuretics, and alcohol abuse, another very common topic. Right? So you have to be very careful to see that how much magnesium is being lost. All of these things actually increase PTH secretion, but if you lost almost all of your magnesium, then that decreases PTH secretion. Right, so that's something that you're going to have to make sure you recall and can actually apply. So then coming back to here, you have the same diagram from step 1, right? If you have low calcium, high phosphate, or low vitamin D, or slightly low magnesium, your PTH is going to be released. Right, so another thing you could add here is also this one arrow low magnesium, as we just saw. PTH will then go and have two actions immediately. One is this direction, which is related to vitamin D. Right? It actually goes and upregulates 1-alpha hydroxylase activity, which then causes this vitamin D to go to bone and intestines and kidneys. In the bone, right, there's more calcium and phosphate released from the bone, and in the intestines, there's more calcium and phosphate being absorbed. Overall, it increases your both guys, calcium and phosphate. In this direction here, effect number 2, so this is effect 1, this is effect 2. You can label them 1 or 2 how you want. I'm just doing it because that's the order I'm talking about them in. It also goes to the kidneys, where it also activates vitamin D synthesis. But in the kidney, the vitamin D synthesis is different. Here, you get reabsorption of calcium, but you don't reabsorb phosphate. It would be stupid to reabsorb both calcium and phosphate in here, because then you can make hydroxyapatite stones, right? Calcium phosphate stones, which are going to get stuck in here, and you're going to have nephrolithiasis, and that's not a good feeling. So in the urine, you're just going to urinate all your phosphate. All right, so that's your main thing here. And of course, vitamin D also has a feedback inhibition of PTH synthesis. Once you actually make your vitamin D, you already did your job, so the vitamin D goes back and tells your PTH to stop making more PTH hormone. So that's that topic right there. That finished up basically osteoporosis. Here you have another question where again you can see 50 versus 30. Right, so there's a pretty big gap of how many people chose that one same wrong answer choice. 45-year-old woman comes to a physician complaining of fatigue, weakness, and diffuse bone pain. She was diagnosed with celiac sprue 5 years ago and admits to being non-compliant with her diet. She takes over-the-counter folic acid and iron supplements. I highly recommend you guys also grab like coffee or something when you're watching these videos. It'll definitely help you develop a nice little relaxing gesture. You know, I really just drink tea and coffee and stuff as not something like I'm addicted to it or habitual or something. It's more so just because it's a good way to measure time is going, and it's like a little thing I can do. It's a mini activity to do to take like a quick little break and look away from the screen. So it's nice. In my opinion, it's basically just a fancy thing. So she's taking good supplements. Okay. Lab results are as follows. Hemoglobin is 12.2, calcium 9, phosphate is low. Right? Phosphate is low, 2.6. It's supposed to be 3 to 4.5. PTH is 122, which is high. Okay. And alkaline phosphatase, ALK-Phos level, is very high, which indicates that she has a lot of osteoblast activity. What is directly responsible for her condition? Alright, so what's causing her condition? What is the issue with her? So the correct answer here was impaired osteoid matrix mineralization, but 30% of people chose accelerated bone remodeling. The above issue that she has is actually, well, this above table here, osteomalacia table, was given, so a good table to have there. Remember, this is something that you're always going to have to compare to osteoporosis. Osteomalacia, though, is a vitamin deficiency. You don't have vitamin D in these people, right? This is actually the key thing here. They don't have vitamin D. Osteoporosis is a metabolic issue, right? So the above table is given. Her presentation actually suggests osteomalacia, which is due to defective mineralization of the organic bone matrix. During new bone formation and remodeling, osteoclasts create a cavity at the bone surface for osteoblasts to fill with organic matrix. Calcium and phosphorus then deposit in the matrix to provide adequate mineralization. Thus, calcium or phosphorus deficiency will lead to inadequate mineralization. Osteomalacia is most commonly due to vitamin D deficiency, which can be due to malabsorption, intestinal bypass surgery, celiac sprue, or chronic hepatic or renal failure. Accelerated remodeling, the other choice most people chose, is something you see in Paget disease of bone. Right, so this definitely wasn't osteoporosis though, because although she does have weakness and diffuse bone pain, and she has this history of celiac sprue, the celiac sprue history that they've mentioned is the one that would make you think, okay, why would this question be a patient that has celiac sprue? The celiac sprue has nothing to do with osteoporosis. Right? So she admits to being non-compliant with her diet, which further helps you think she's probably not eating correctly or doing stuff the right way. Okay. So some of the things that they mentioned in this question are things you just wouldn't see if the question was about osteoporosis, right? And she would have like some kind of fracture, some kind of other issue, anything that's more osteoporosis-y, whereas these things, right? These are some of the things they mentioned in the question. Think about it like this. The test writers use these same tables, in a sense, to put together your question. So they're going to give you a patient who maybe has two of these things, right, and tell you that the patient has this symptom, and then they give you all these labs, and then you ask you a question. Or they give you some of these labs, and then ask you a question on maybe this topic. The correct answer would be this one. Right, so that's basically what they did here. Right, in another test writer, they might actually talk to you about someone who did intestinal bypass surgery, lost weight, now they have bone pain and muscle weakness, also muscle cramp. Right, they'll do the same thing again, give you the labs, alk-phos, calcium phosphorus, PTH. Maybe not mention the vitamin D thing because this is actually the key diagnostic feature in this osteomalacia condition. And then ask you a question where they're going to want you to pick something and you would pick pseudo-fractures. They have pseudo-fractures, by the way. Keep that in mind too. It's not really like a full-blown fracture the way you would see in osteoporosis. Right? So, you know, my problem with this question was that why did people pick accelerated remodeling? That didn't make sense to me because accelerated remodeling is a key phrase for Paget disease of bone, which this definitely was not. This is not Paget disease of bone. If you do enough questions on topics, you start seeing the key terms, key topics that are related to various conditions. And anytime they talk about Paget disease of bone, they'll often talk about accelerated redesigning or accelerated remodeling of the bone. Here you can see a very nice x-ray again. It won't be this nice to you on step one, where there is a what do you call it? Compression fracture. Right, so here, what did they write? Thoracic spine, anterior wedge deformity, vertebral body with associated kyphosis, insufficiency, fracture. Okay. So basically what you're seeing is you could definitely see the lines of each of the vertebral bodies, right? And these ones I've made, these is two of them. This is one, this is two. Those are fine. This third guy is also fine. But then here something weird has happened, right? This is the wedge they're talking about. Okay, that's the wedge they're talking about right here, right? And then after that, these guys are okay too. So this is a compression fracture that has occurred here, which of course is causing a kyphosis. That's why she has this weird curvature on the back. Right, and then this patient would need a lot of help. Remember, keep in mind that bone issues are also often related to respiratory difficulties because If the bone is not working well, especially if the rib cage has issues, then your lungs cannot expand or stand the correct way, right? This patient's lung is going to get pretty messed up too, right? Especially if the patient is obese and stuff, it gets even worse. Next comes the topic of Paget disease of bone. Another high yield topic, a lot of good pictures, and very easy topic to catch. You can see some pretty specific things in these questions. Characterized by an increased rate of bone turnover with both excessive resorption and formation of bone, leading to a mosaic lamellar bone pattern appearance on X-ray. Right. So all the things you read are basically key phrases that are going to pop up in answer choices. Suspected to be caused by the effects of a latent viral infection in genetically susceptible individuals, associated with primary hyperparathyroidism and increased risk for osteosarcoma, something that pops up in questions as well. As this would be another answer choice. The patient is at risk of osteosarcoma. The disease can affect one or more bones, with the skull, vertebral bodies, pelvis, and long bones most commonly being affected. Now what you need to know is how are they affected. So patients are usually going to be asymptomatic, but they could present with aching bone or joint pain, bony deformities, fracture at a pagetoid site, nerve entrapment, headaches, and hearing loss. The latter two occur if it involves the skull, which it often will. Not only do you hear about headaches and hearing loss, you also notice that the patient might tell you weird scenarios where like their hat doesn't fit anymore because their skull got bigger, right? Something like that. So the best initial test to do, and this is often of course on CK it's even a bigger. This is often a question, and on CK it's an even bigger question. This was even asked in step 1. What should you order? Right? And then people were confused because they had all these answer choices, and picking an answer choice like plain X-ray sounds very benign and dull and useless, but actually all you do is just a plain X-ray. Right? All you need to do is plain X-ray. And this is going to show you the lytic and sclerotic lesions, as you can see. Right? So in this image here, you're seeing something's clearly wrong with this patient's. I think this is their left leg. Yeah. Patient's left leg. There's something's clearly wrong with this patient's left leg, and this is from the back, again showing you their left leg. All right. So what's happening? So up here you're seeing a radionuclide bone scan in Paget disease. Dark areas represent increased bone-seeking isotope uptake and depict severe disease in the left femur. All right. So that's the other thing you can order: a radionuclide bone scan, necessary to characterize the extent and sites of disease. And so remember, CK always asks what is the next best step. Don't jump to a radionuclide bone scan if you haven't yet done the plain film X-ray. Right here on the left, you're seeing another image: radiographic findings in Paget disease. Pelvic radiograph demonstrates a thickened cortex, thickened trabeculae, and expansion of the right femoral head. Classic signs of Paget disease. Right, so you have to make sure you can catch it. Generally speaking, some of these things are going to be pretty hard to see, but the most obvious one to see is this. This is pretty thick compared to here. This is not as thick, and that's what they're comparing with the red arrow, the full arrow. This is very, very thick here compared to the other side, and the other side is probably thicker compared to normal. So yeah, this patient has problems. And then with the arrowhead, they're talking about thickened trabeculae, but that's a little harder to see. You need a trained eye to see it. What they're actually pointing at is the trabecular formations in here. Too thick. You see there's nothing here per se on this side. Lines like this are not in here on the other side. But here it goes up. This gray area goes up like that. So that's what you need to train your eyes for, basically. Some key things you would see are like that in Paget disease. Right? I'm going to show you Paget disease from here as well. So let's see. Here there was a little more discussion of it. So Paget disease of bone, I believe, was also in here in MSK. Yeah. So these few pages actually are very high yield stuff, right? So you're gonna start with right here in first aid step 1. This is the 2019-2020 version. So you're gonna have your 2 types of fractures: achondroplasia regarding the fibroblast growth factor receptor 3. Osteoporosis, we talked about, and then osteomalacia, we talked about. Osteopetrosis is basically the opposite of osteoporosis. They have too much calcium and too much bone. This is your osteitis deformans, which is your Paget disease of the bone. Right? And then avascular necrosis of the bone, one of the key things that are related to your hip area, right? There's a bunch of different diseases that show up with the same stuff. Infarct of the bone and marrow, very, very painful stuff. High yield topic for leg calcaneus disease, Gaucher disease, even slip capitofemoral epiphysis, or the use of extensive corticosteroids, and sickle cell, very high yield in sickle cell as well. And this lab value stuff, super high yield, we're going to look at this too. And the fact that you're at risk of osteosarcoma. Right, so let's go up now to look at Paget disease of bone. This one here, what you're seeing is common localized disorder of bone remodeling. Right, so that's the key phrase, bone remodeling, caused by increased osteoclastic activity, followed by increased osteoblastic activity. So first you break it, then you make it again, right? And this breaking and making is something that normally occurs in all of our bones, but here it's happening too much, leading to forming poor quality bone, right? And that's bad. That's going to be at risk of fracture, right? So that's the stages that you're seeing here, right? You have a lytic stage where you break it, you have a mixed stage where you're starting to rebuild it, and then you have a sclerotic phase where you rebuild it, but you don't build it too well. And this is also treated with bisphosphonates, just like you were treating your osteoporosis, because bisphosphonates would stop the osteoclast activity. Right? And these patients could have a couple other case scenarios, so I put that into this mnemonic Paget. P for picture frame bone. This is looking like a picture frame, right? It's a picture frame. You put your picture in the middle here. AV shunts, which can lead to heart failure, mainly high output heart failure. So keep in mind you're making too much bone. Some of your bones could end up ripping through arteries and connecting it to a vein. You got an AV shunt, and AV shunts are terrible because AV shunts effectively mean you have double the number of arteries and double the number of veins, and you do not want that, right? So that's not good. And then hat size can be increased, like I mentioned earlier. Hearing loss is common due to auditory foramen narrowing, and many of the cranial nerves could get compressed. The last thing is the T in Paget, which should remind you of a triangle. The triangle being the Codman triangle that you see in osteosarcoma. Right, so osteosarcoma is one of your 3 high-yield malignant tumors. Really bad stuff. You see sheets of malignant pleomorphic cells in histology. And malignant pleomorphic cells are being pointed out here in these black arrows right there. And these are all these cells that are not supposed to be there at all. So Ewing sarcoma also has malignant Homer Wright rosettes. So these histologies are things that could pop up in questions. You don't have to know the histology perfectly, as long as you know there is some association, so that if such an image is given, even if you don't have the trained eye to see anything in this image, at least you know that if such an image is given, it must be talking about osteosarcoma. And then this is the Codman triangle thing. A sunburst pattern on X-ray due to weird elevation of the periosteum during abnormal bone development, bone remodeling. All right, so that's what you're seeing there. And then this lab value thing, super high yield, right? Because this is what's going to help you really easily differentiate between many things. If you have a question, and you think the question is about osteoporosis, then keep in mind their labs should be normal with regards to these guys: calcium phosphate, ALP, and PTH. And the only issue they have here, the real issue in osteoporosis, is low estrogen or low osteoprotegrin in general. That's the real issue, all right? And then Paget disease of bone, same thing. Everything should be normal. Of course, because they have more osteoclast and osteoblast activity, the increased osteoblast activity will cause some ALP formation to occur. But calcium, phosphate, and PTH should be normal, right? So any of these other things that are related to PTH are actually a PTH problem. Here, for example, primary PTHism, hyperparathyroidism, is going to be the one that leads to brown tumors due to fibrous replacement of bone with subperiosteal thinning. Right? It could be idiopathic, or it could be due to a carcinoma, adenoma, anything like that, but you're making too much PTH, which of course means you're going to have high calcium, and then PTH is going to also upregulate osteoblast activity, right? And osteoblasts are also going to upregulate osteoclast activity, and all of that's going to occur, so osteoblast activity is high, PTH trashes your phosphate. Right? In secondary hyperparathyroidism, you make a lot of PTH secondary to the fact that there's low calcium. Why is there low calcium? Well, this is something that occurs commonly in patients with chronic kidney disease. So anytime you ever get a question about a patient with chronic kidney disease, you start thinking immediately, oh shit, your kidney's not working. That means you can't really make vitamin D that well, and your calcium levels are not going to be that good. Because if your kidney's not working, a lot of your levels are not going to be good. you're just going to pee everything out because your kidney is unable to filter correctly and reabsorb correctly. Alright, so low calcium, so they make a lot of PTH. PTH upregulates osteoblast activity. PTH upregulates phosphate trashing. Alright, osteomalacia or rickets are just poor eating. This is just a vitamin deficiency disease. This is basically biochem nutrition. So the key issue here isn't that any of these guys are the cause. The cause is vitamin D deficiency. And if you don't have vitamin D, then you're going to have low calcium. Alright, so osteomalacia is sort of, in a sense, your secondary hyperparathyroidism in a sense. But this is different. So what's happening here that's different from secondary hyperparathyroidism is that PTH-related phosphate level. Look at this. This is the difference here. So why did this difference occur? Well, there's a very key reason for that. This person did not have vitamin D, so they don't have calcium. Since they don't have calcium, they make PTH. PTH is a phosphate trashing hormone. Right? So this is what you expect. In fact, generally speaking, anytime PTH is high, you expect phosphate to be low. So what happened here? Well, this is a trick thing that STEP loves talking about, the rectangle area. STEP loves talking about this. Right? This is something that almost everyone messes up in all of those questions about a patient with chronic kidney disease, up and down arrows. All of these things are the parameters, and you mess it up. Why do you mess it up? Because you don't realize that the kidney is not working. You forget about that. Think of it. Come back to secondary hyperparathyroidism. This is a really important topic to grasp. It's very important to confidently know. If your patient has kidney disease and the kidney is not working, then you have to keep in mind the kidney is not working. So because the kidney is not working, they lost calcium. Since they lost calcium, their brain, their pituitary, all the other things are working, so it's successfully made PTH. PTH will go to osteoblasts who are working and increase osteoblast activity. However, PTH has to go to the kidney to do the phosphate trashing, and that will not work. The kidney is not working. Very critical thing right here that a lot of people mess up. It's a very easy trick to fall for. Don't fall for it. Don't fall for it. You do not want to fall for this little trick here. It's very hard to avoid it, especially if you're burned out. But just remember, secondary hyperparathyroidism, you really want to just associate this directly to chronic kidney disease. It's really the only reason someone would actually have significantly low calcium levels that are not getting managed well. All right. And then hypervitaminosis D, this one is the opposite of osteomalacia in a sense. And what happens here is you have too much vitamin D, mainly due to some kind of granulomatous disease. Always remember that granulomas have macrophages, and macrophages also upregulate 1-alpha hydroxylase activity and lead to vitamin D activity within the granuloma. So that's another weird physiology you need to remember. All right. So if anything, just always remember the secondary hyperparathyroidism. Although you do make a lot of PTH, PTH cannot make phosphate get trashed because the kidney is not working. You need the kidney to work for the PTH to have this effect. But all the other effects will occur. PTH will activate osteoblasts. PTH will eventually fix calcium levels by stripping calcium from your bones. Right? And then the patient is going to be in a weird condition where things are just going to keep getting worse. Because although you'll fix the calcium, their bad kidney is going to cause even that calcium to get lost too. Alright, so treatment-wise and stuff, pretty much the same stuff as we talked about before. We just basically talked about hyperparathyroidism on that table, right? This is the diagnosis of hypercalcemia. Anytime a patient comes in with hypercalcemia, what's the next best step? Confirm the hypercalcemia by doing repeat testing and correct it for albumin concentration or measured ionized calcium. This correction is what I had the equation for at the beginning of today's video. Right, correcting it. The corrected calcium is your measured calcium plus 0.8 times 4 albumin. Right, 4 minus albumin, excuse me. Right, 0.8 times 4 minus whatever the albumin level is. Right, so if the albumin level is 2, it would be 4 minus 2, which is 2, so 0.8 times 2. And then whatever 0.8 times 2 is, you add that to their measured calcium. That would be the corrected calcium. What is it correcting for? It's correcting for how much calcium is actually just stuck to albumin. That's all it's correcting. All right. So if you do all of that, you do a repeat test, and then you measure PTH level. Now you can figure out what's happening. If PTH is high, then the reason for their hypercalcemia is the high PTH. Right? So now you know that they have some kind of hyperparathyroidism. If PTH is low, then they have hypercalcemia due to some kind of secondary thing that's acting like PTH, which is your PTH-related peptide found in lung cancer, right? Malignancy. Right? So that's another big topic that STEP loves talking about. So here you have your different types of hyperparathyroidism, which are all pretty straightforward. And just remember, secondary hyperparathyroidism, you can have all the up and down arrows, but here in secondary you're going to have high phosphate too, because you're unable to throw out the phosphate because the kidney's not working. The topics of pseudo-hypoparathyroidism is basically, this looks like hyperparathyroidism, but it's not. Right? So this patient, what's going to happen is very interesting. This disease is called pseudo-hypo. However, they're going to have high PTH, which will make you think of hyper, but then all their labs are going to not really match. So this is one other case scenario that has weird up and down arrows. They're going to have a low calcium, right? So the hypocalcemia. They're going to have high phosphate, okay? And then they're also going to have high PTH, which doesn't make sense. It's like you're making all this PTH, but then your calcium didn't go up, your phosphate didn't go down. What's the problem? Well, the problem is that you're making all this PTH, but your body is just not responding to it. Right? This is something that's associated with Albright hereditary osteodystrophy, where they could have a shortened 4th and 5th metatarsal or metacarpal bones. And this is just a resistance to the PTH. So you're making a lot of PTH, but none of it is actually working. That's all this is. Right? And this topic actually gets even more confusing in step 1. And those things that they talk about here actually come back still. Right? So they're in CK2. You could see it in step 1 CK and U World CK. So hypoparathyroidism, low PTH, right? Due to injury to the parathyroid glands or their blood supply, usually during surgery, could also be autoimmune destruction, or you could have DeGeorge syndrome. Any of these are case scenarios where you would not have PTH formation. So what do you notice? Well, you see tetany, hypocalcemia, and hyperphosphatemia. You could check for these physical exam signs, the Chvostek sign here and the Trousseau sign here, with your blood pressure cuffs, and you can notice weird spasms. Right? The patient might even actually tell you that they get spasms at night where their big toe just starts pulling in a really weird, strong sensation. Right? So that's when you know that they have hypoparathyroidism, which is causing them to have symptoms of hypocalcemia. But then you have type 1A and this one, which are both pseudos. So the first one here is pseudo-hypoparathyroidism. This is an autosomal dominant condition that you're going to note is associated with family history and is due to an inactive GS protein, alpha subunit, causing end organ resistance to PTH. The PTH doesn't do anything on osteoblasts or the kidney. Presents as a constellation of physical findings known as Albright hereditary osteodystrophy with the shortened fingers and obesity and developmental delay. Right? The defect must be inherited from the mother due to imprinting. So this is one of those imprinting things. Great question in step 1 because it combines endocrine and genetics and a bunch of other stuff, which really gets very annoying. But then you have this other autosomal dominant guy that's pseudo-hypoparathyroidism. It's like a fake version of this fake disease. So what's happening here? Physical exam features are going to be the same without end organ PTH resistance. That's why they named it that. This is a guy that looks like someone who has this disease up here. So the pseudo actually is someone that looks like type 1A, but isn't. That's why it's a pseudo. It's a fake. Right? It's a fake version of this one here. Right? And this one, the pseudo one, is actually inherited from the father in imprinting, and normal maternal allele actually maintains responsiveness of kidney to PTH. So there's 2 different weird low-yield diseases that would just be really annoying to see in a question, that's all. So you don't need to master those kind of questions, you just need to make sure you know that they exist and you can see them in questions and be able to pick them as an answer choice. Right? The hyperparathyroidisms we see right here, right? All the symptoms of hypercalcemia will pop up, stones, thrones, groans, psychiatric overtones, all these other things, and want to make sure you get that. And then here you have your osteitis fibrosa cystica, which is the cystic brown fibrous tissue thing we just read about a little while ago. due to high PTH, classically associated with primary hyperparathyroidism. Right, this also is a condition we talked about not too long ago, renal osteodystrophy. I was telling you guys how this is actually sort of an unfair disease name because it's called renal osteodystrophy, but your kidneys actually try to do the best they can. This is a condition where because of your renal disease, you end up having secondary hyperparathyroidism, which then leads to bone lesions. But your kidney's really trying to do what it can. And this topic is discussed much more when you get to renal. And then I have some notes over here to help you see what else you might need to know. But generally speaking, this is definitely something very good to come back and look at and make sure that you have it down. The last thing is your familial hypocalciuric hypercalcemia, FHH. This topic I talk about more right here, and I think these questions are also encompassing those things, so you could definitely feel free to pause anywhere and check it all out. Right, so yeah, right here it fits everything. So FHH is actually a defective G-coupled calcium sensing receptor. CASR is not working, calcium sensing receptor. So that means that you are unable to sense how much calcium you have. So the patient will end up having higher than normal calcium levels because they can't tell that they have enough calcium, so they need to make a lot more calcium to be able to tell the fact that they actually have enough calcium. So maybe for every 10 calcium they make, they kind of can't recognize one of them. Right, so they have to make more calcium. This ends up suppressing PTH. Excessive renal calcium reabsorption is going to occur, leading to mild hypercalcemia and hypocalciuria with normal to high PTH levels. This is a very interesting case scenario. Look at this note. FHH is an autosomal dominant disorder in which high calcium does not inhibit PTH like it normally should, leading to higher calcium than normal. It's not like the PTH has run amok, so this is different from hyperparathyroidism. What else regulates PTH? Phosphate does, and to a lesser extent, as we saw, magnesium. A drop in phosphate will still inhibit PTH, so the hypercalcemia will be mild, and PTH will be pretty mildly changed too. Which lab value distinguishes FHH and hyperparathyroidism? Urine calcium. Even though PTH controls calcium excretion to some extent, if calcium is really high, kidneys will start dumping it. However, in FHH, there is a mild alteration of calcium, so the high PTH actually decreases calcium excretion. So although a mild disease, it's unique in that it's got low urine calcium combined with an elevated serum calcium. While in other cases, urine calcium, remember this, urine calcium mirrors serum calcium rather than the PTH. Alright? So urine calcium should be mirroring serum calcium. If your serum calcium is very high, you should have a lot of urine calcium too because you're dumping it out. And PTH should end up getting suppressed because of all the calcium you have. If you don't notice those things happening, then it's FHH. And there's going to be some family history too. And this question here about the 14-year-old boy was regarding that topic. So that takes care of basically your various hyper and hypoparathyroidisms. Diagnosis is almost always going to be a pretty straightforward thing. You just do the labs, look at PTH, and then you move on. Right? You could do a 99 MTC system scan. This thing is a weird answer choice in conjunction with thyroid ultrasonography to localize any solitary adenoma. The same technetium thing we were doing in thyroid also, right? Just to find any nodules. DEXA scan may reveal low bone mineral density or frank osteoporosis in the distal radius or other sides. And consider renal imaging to look for nephrocalcinosis or nephrolithiasis, because if you have hyperparathyroidism, you're going to have hypercalcemia, and all that calcium is going to get stuck in places, leading to calcium stones. All right. Best initial treatment for acute hypercalcemia, just give them IV fluids and use calcitonin, a hormone that you can make too, but doesn't really serve much purpose. In fact, we barely ever really make it. But it tones down calcium levels. Okay? Consider IV bisphosphonates for long-term parathyroidectomy if the patient is symptomatic or if certain criteria are met. But again, parathyroidectomy, you want to try to avoid that because parathyroidectomy always has a risk factor of messing up the vagus nerves and other nerves that are in that area, and you can actually cause organ damage to the thyroid gland as well. But if it's necessary, you'll have to do it, especially in the case of a solitary adenoma. Right, but if there's a solitary adenoma, one gland can be removed. In the setting of hyperplasia, 3.5 glands must be removed. Right, so here, again, you're seeing some technical stuff, so make sure you get it. What is the point of removing 3.5 glands? Because if you could leave something, at least you have some PTH formation, right? It's better than not having any PTH formation. And so that's the aspect of hyperplasia. In a person with hyperplasia, the remaining 0.5 will actually be big and do enough job of probably just one entire gland itself, right? So that's why you could leave 0.5 behind. Okay. Last thing here, this table, very nice, right? Hypercalcemia of malignancy. So there's a connection with albumin, right? As we already saw, because the equation we were looking at had to do with correcting, right? Correcting calcium levels based off of albumin. So measured in actual. There's many hypercalcemias of malignancy. You could either have PTH-related peptide, bone metastases from another cancer, or vitamin D because of some kind of lymphoma. Right, so these guys are all high-yield topics, especially the first two. Most high-yield PTH-related peptide from squamous cell carcinoma of the lung, where you make a peptide that mimics PTH. Right, so the patient will have low PTH, but they're going to have symptoms of high PTH. That's really weird. The bone metastases from cancer is usually going to be breast cancer that causes the bone metastases, and it's going to be mainly osteolytic. That's what you're looking for, right? And then the vitamin D thing, well, you're going to have lymphoma that's making too much vitamin D, which causes more calcium absorption. In all three case scenarios, PTH is low. All three case scenarios. All three hypercalcemia of malignancy. It is a hypercalcemia where your PTH is low. All right. Now this image here is showing you acid-base shifts in calcium homeostasis. Right? There's acidosis and alkalosis. So what you're noticing is some of the blue calcium circles got replaced by the green hydrogen circles. So that means that hydrogen and calcium compete with each other. So what's happening? Well, if a person has acidosis, right? If a person has acidosis, low pH, what you're going to see is this case scenario. Low pH, always think of it like this. They go together. Low pH equals low PTH. Right? This person has low pH, they're acidotic, they have too much acidemia. Many hydrogen means that few calcium will bind to anions in albumin. My cat's like dying or something. This is terrible. Whatever. Excuse the kitty, please. So low pH. This is a weird question you get, and where they're going to tell you the patient has acidosis and stuff, and then they'll ask you either with up and down arrows like this, and they'll have PTH as one of the parameters. Or they'll just ask you what's going to happen in PTH, or which one of these values will be decreased, and PTH will be the correct answer. Right, so low pH, low PTH. Having too much hydrogen causes you to actually have more free calcium. The calcium got displaced off of the albumin. Right? Imagine you had originally a calcium here and a calcium here and a calcium here. Those three calciums got removed off the albumin. So now you're going to have more free calcium. So more free calcium is going to suppress PTH. Opposite to that, you have the case scenario of alkalosis, a high pH, right? Very high pH. So high pH leads to high PTH, because if you have alkalosis, you don't have enough H+, so more calcium got stuck onto the albumin. So then you have a lower amount of free calcium. Lower free calcium causes your body to make more PTH to fix the amount of calcium you have. And that's all you really see there. So again, nothing about PTH and calcium is very, very, very confusing. I think the most intricate topics are this one here, the topic of magnesium, where if magnesium is super low, then you get low PTH. And then the topic of chronic kidney disease, which you solidify even more. If you want to do a shock study, you could jump to renal, check out chronic kidney disease right here, and you'll see the topic of chronic kidney disease and what it all does. Skip over the acid-base disorder stuff. I'm still putting in questions there, but yeah, chronic kidney disease, all the chronic kidney disease topics right here. And you're going to see that in these people, the main issue, here they don't even really talk about it too much, right? But there is a thing. You would need oral phosphate binders. And there's this thing right here. Why would you need this? This is a new topic from CK that you would need to grasp when you get there. And it's all related to the fact that these people, you're making PTH, right? And why are you making PTH? Because you have CKD. So if you have CKD, right, CKD means that you lose calcium because you just pee it all out, right? So if you lose calcium, you go ahead and make PTH, right? Your PTH will go ahead and do a couple things. It will be successfully able to go to bone, and increase osteoblast activity, so you're going to have more ALP, right? It's going to successfully go to your kidneys, but what's going to happen in the kidney? Kidney fails. Kidney is not working. So in the kidney, it's not going to do decreasing phosphate. So phosphate will be retained. Right? It was supposed to do the trashing of phosphate, but phosphate is going to end up retained. This is not going to work because the kidney is not working. And so that's the key thing you want to remember. Will it be able to fix calcium? Well, it's going to try to. It'll go to bone, as I said up here, right? Bone ALP, which is going to increase calcium, but then again, you're just going to fall into the same cycle of losing calcium. So what's going to end up happening to these people? Well, if you keep losing calcium and you keep making PTH to increase calcium, you're recycling yourself in this loop over here, and every time this loop occurs, this occurs, which means you're going to break down all your bone. Right, so chronic kidney disease is a progressive disorder where you need to maintain the patient, otherwise they're going to lose all their bone, and that would suck. Right, so always remember, phosphate doesn't go low. Every time you have high PTH, generally speaking, you're going to have low phosphate. But this only occurs because the PTH successfully got to the kidney and did the phosphate trashing. If the kidney is not working, this will not occur. Right, so that's your topic of chronic kidney disease. All right. So that wraps up bone mineral disorders, and then in the next session, tomorrow, 5 p.m., I'll talk to you guys about pituitary and hypothalamic disorders.